thank you for coming out on this rainy fall November evening. I think we have had a fairly mild fall so far. I think last year at this time there might have even been a fair bit of snow in Buffalo. So again, thanks for coming out. My name is Ann White. I am part of the administrative staff of Meadville Medical Center, and I'm pleased that you are able to join us for tonight's topic on hypertension. Dr. Zellin, take it away.
I will. Now, you might want to turn around so you don't have a stiff neck when we're finished. Now, when we talk about hypertension, everybody has their own idea what high blood pressure is. So let me just hear what your ideas of high blood pressure are so I can start somewhere. What do you think high blood pressure is?
It's always 120 over.
Okay, that's a number, but do you have any idea what it means? Or how we get two different numbers for the blood pressure? Okay, those are the names.
But as the decade went by, it went up to 135, and then it dropped up to 140. Then starting about a year ago, it spiked up significantly higher than that.
That's your blood pressure? That you're talking about your blood pressure?
Yeah.
Okay. Anybody else have an idea what blood pressure means?
Number is the pressure that your heart is exerting when it compresses or I don't know, which has gone bad now.
That's
and
okay.
Diastolic is when your heart is at rest and is not putting pressure, pushing the blood through the vessels.
Okay, so I'm going to run with that. How many of you believe that the pressure to actually move blood through your body comes from the heart? And most of you believe that. So if that was true, and your thought was true, then when the heart squeezes, we would have a spike in the blood pressure, and when the heart is relaxing and refilling, the blood pressure would be zero. Is that in fact what we see? But if our heart squeezes blood and then has to refill, then if the pressure truly came from the heart, then what we would have is a spike as the heart was squeezing, and when the heart was relaxing and refilling, the pressure would go to zero. But in fact, we don't see that. And the reason we don't see that is that our pressure actually comes from a big blood vessel in our chest called the aorta. And the purpose of the heart is actually to refill that blood vessel. So the pressure to your tissue actually comes from the aorta. So let's think this through now. My heart squeezes, and it's pushing blood into that big blood vessel called the aorta. And as it's pushing the blood in, the aorta expands, and it's an elastic structure. So it expands, and as it does expand, the pressure in the aorta goes up. And when the heart is completely emptied and just begins to relax, valves close, preventing blood from going back into the heart. And at that moment when the heart is just finished squeezing, the pressure in that aorta is as high as it's ever going to get. And that's the systolic pressure. Now the heart begins to refill, and blood is slowly let out of that aorta, pushing it out into the tissue. And as it does that, the aorta shrinks in size, and the pressure begins to go down. Now the heart is refilled, and at the moment the heart begins to squeeze again and push blood back into the aorta, the pressure in the aorta is as low as it's ever going to get. And that's the diastolic number. So the actual blood flow comes from that big blood vessel, not from the heart. Isn't that interesting? And that's why we have the two numbers. We have the number when the aorta is as full as it's ever going to get and the pressure is its highest. And the other number is when the aorta is as small as it's ever going to get, the pressure is its lowest, and just before the heart begins to contract and refill it. And that's how we get continuous flow. That's the reason we don't have a spike and a zero. because the pressure actually comes from that big blood vessel. Now, as we age, that blood vessel becomes stiffer. And as the blood goes into that aorta, there's a greater amount of pressure in it because it can't expand as easily. So for many years, we thought that as we age, the blood pressure naturally should get higher and higher and higher, as you were alluding to. But in fact, we now realize that's not a good thing. And if we allow the blood pressure to increase with age, we have more strokes and more heart attacks. So we now have set targets for what the blood pressure should be at all points of life. The top number should be 110 to 130, and the bottom number is 60 to 80. That's the range that we want to stay in. So if the blood pressure is 150 and you're 80 years old and your doctor says that's perfectly fine, it is not perfectly fine. Now there's another little wrinkle in this, and there's something called pseudo hypertension. Now if you look at a blood vessel, the artery in a youngster, you can squeeze it with no resistance. I can squeeze it flat and it takes no effort. In an 80-year-old, that blood vessel has calcium in it. And it becomes really difficult to squeeze the blood vessel. So when you put a blood pressure machine on, some of the pressure in that 80-year-old is being used to squeeze the blood vessel wall, not to squeeze the blood inside the blood vessel. So in some people, their blood pressure could be 150 because 20 millimeters is actually being used to squeeze the blood vessel wall. So occasionally I'll find somebody whose blood pressure is 150, and anytime they get less than that, they get lightheaded. And those people could have an element of pseudo is false, pseudo hypertension. Okay? So now we have an idea why we have a systolic and a diastolic, and that the pressure actually doesn't come from the heart. So you are a select few in the planet that actually know this now. Most of my physician colleagues don't know this. Now, let's talk for a minute about what outside of medicine we can use to affect our blood pressure. So somebody throw out something that might affect the blood pressure that we can deal with without any medicine. Okay, what about the diet?
Sodium.
Sodium. Why does sodium cause the blood pressure to go up? You know?
Because it reduces the amount of fluid, makes the fluid more difficult.
Okay, well actually, when you have a lot of salt in your body, let me backtrack a little bit. Blood pressure comes from 3 different forces inside your body. You have a heart that pumps the blood. You have the blood vessels, which actually can change their size. They can constrict and dilate. And inside those blood vessels is blood. If you have a heart that's pumping too much blood, and the blood vessels are the correct size, then the energy needed to pump a lot of blood through a small tube causes the blood pressure to be elevated. So if your heart is pumping too much blood, you have high blood pressure. If the heart is pumping the right amount of blood, but the blood vessels are overly constricted, so now I have the right amount of fluid, but it's going through a tube that's too small. I need more pressure to drive blood through a tiny tube, so the end result is high blood pressure. If my heart is pumping the right amount of blood, and my blood vessels are the right size, but I overfill them with fluid. So normally we have about 6 quarts of blood. So if I take a 6-quart container and I put a pressure monitor in the top and I put a pump on the side and I start pushing more fluid in, what happens? The walls of my container begin to balloon out and the pressure inside the container goes up astronomically because you can't compress fluid. So if you push extra fluid in a container of a certain size, the pressure goes up. If you retain salt, what you're doing is forcing too much fluid inside the blood vessels. So you're overfilling the blood vessels, and just like your container where the sides ballooned out, that's what happens inside your body. So when you consume a lot of salt, you're overfilling the blood vessels. And if the heart's pumping the right amount of blood, and the blood vessels are the right size, but they're overfilled, your blood pressure goes up. So how do we deal with this? What do we recommend when somebody has high blood pressure? We recommend a low salt diet, right? Now, a lot of people believe that if you're not adding table salt, you're on a low salt diet. Is that true? No. But I'll line up 100 of my patients and they'll all tell you, I threw out the salt shaker, thus I am on a low salt diet. That is not in fact the case. If you're on a low salt diet, you also have to limit fluid. Because if you don't limit fluid, but you limit salt, you can actually get diluted internally. Now this is a fun one that I get into a lot with my patients. Let's suppose somebody consumes 2 quarts a day and they urinate 1 quart. You can see that they're holding on to fluid. So have any of you heard of diuretics? Diuretics make you pee more. So, being the good doc that I am, I put them on a diuretic. Now they urinate 3 quarts a day. But guess what happens? They get more thirsty, so they drink 4 quarts. Have I accomplished anything? I have not. So, undaunted, I give them more diuretics. Now they urinate 5 quarts a day. But they get thirstier yet, so they drink 6 quarts. Have we accomplished anything? No. I make them P8, they drink 9. I make them P10, they drink 11. Their whole life is peeing and drinking, and they hate me big time. But have I gotten 1 drop of fluid out of their body? I have not. So when somebody is salt and water overloaded, and I treat them with a diuretic, if I don't spend a few minutes with that silly story that I just went through, they will go home, take the diuretics, get more thirsty, drink more fluid, and they'll come back 2 or 3 weeks later just as swollen as they were before, except they're angry at me now because they took the diuretic and nothing happened. And I say, well, let's give you more diuretics. Oh my God, no, I spent the whole day in the toilet already. Well, you can't pee a lot, still have evidence of overload, meaning their feet are swollen. So they're peeing a lot, their feet are swollen, and they swear on a stack of Bibles they consume no salt and no fluid. It can't work that way. So whenever you're on a diuretic, you have to limit how much salt and how much fluid you get. Anybody have any questions on that? All right, we've got a good group here then. So other than salt, what else can affect the blood pressure that we can deal with without any medicine?
Stress.
Okay, excellent. Now, stress is not going to cause high blood pressure in somebody that doesn't already have a tendency towards it, but it will make high blood pressure worse. But you have to already have the high blood pressure. And what can we do about stress?
Retire.
All right, retire, divorce, a whole lot of things you might consider. But in reality, there are biofeedback techniques, there's Tai Chi, there's yoga. There are relaxation techniques that people can actually do. Retirement is nice, but it's not always an option for most people. But there are relaxation techniques that can make a big difference. But that's a really good one. All right, what else? Ah, okay, exercise. How would exercise help your blood pressure?
Weight management.
Well, if you lose weight, which is a separate thing we're going to get to, but if you lower weight, that'll help. But when you exercise, you actually warm up the blood vessels and you dilate them. And when you dilate the blood vessels, as I mentioned before, it's easier now for the blood to flow through the blood vessels, and therefore the blood pressure does come down. And that effect will last for several hours after you finish exercising. So it's not where you exercise and as soon as you're finished it shoots back up again. The benefit lingers for quite a while. What about weight? If you are extra heavy, that will increase the blood pressure. Now, I'm not saying you have to be 300 pounds for this either. A lot of people believe that 3 pounds represents 1 millimeter of mercury. So if you're 30 pounds overweight, then 10 points of your blood pressure could be the weight. Weight is an incredibly powerful force in blood pressure. What else? I'm absolutely shocked that no one comes up with this one. Smoking. Ugh. If you smoke, what does smoking do to blood pressure? Obviously it raises it, but how does it raise it? Yeah, there's nicotine and all sorts of stuff that constrict blood vessels, make it more difficult for blood to flow. So smoking is really, really bad in a gazillion different ways, but it does raise the blood pressure. Anything else?
Drinking.
Alcohol? Okay. Alcohol has a very unique effect in that if you have one of anything, whether it's one glass of beer, not big enough to sit in, just one regular glass of beer, one shot of whiskey, 1 4-ounce glass of wine, it actually has no effect on the blood pressure. If you have 2 or more within 8 hours, it actually raises the blood pressure. So the effect of alcohol is dose dependent. Isn't that interesting? What else? One more big one.
I've almost forgotten that there's this thing called sex.
Sex helps everything. Oh.
Off limits?
It is not. No, why would it be off limits? Interesting stuff on that. They have actually done studies to try to find out in healthy youngsters what happens to the blood pressure during sex and when there's an orgasm. And the first time they did the study, the machinery was set with a maximum of 300 millimeters of mercury. And these were healthy youngsters with no high blood pressure. And half of the kids exceeded 300 millimeters at the time of orgasm. So they set it to go up to 400, and a lot of them went between 3 and 320. So what do you think is going to happen to somebody that has high blood pressure and they have sex? Well, it's what we do recommend is that if I have somebody in the office and they ask me that question, then I'll have them do some exercise in the office like jumping jacks, and we'll just get an idea of what happens in response to exercise. Now, in normal healthy people, the top number goes up a little bit and the bottom number goes down a bit, so that the distance between the two numbers is greater because the heart's pumping faster, blood vessels are naturally dilating, so there's more blood flowing through the whole system. If somebody has a severe high blood pressure response to the exercise in the office, then we have to get their blood pressure under better control before it would be safe for them to have sex. If their blood pressure has a normal physiologic response, meaning top number's up a little bit, bottom number's down a little bit, they can have all the sex they want. Really good question. But there is one other thing, caffeine. What is caffeine?
Stimulant.
Exactly. And what happens if you take a stimulant if you have high blood pressure? It goes up. Now the problem with caffeine is that in most things that are constant, we can make an adjustment in blood pressure medicine. But if you take caffeine, let's say you have 2-3 cups of coffee in the morning, and then you don't have any later in the day, but I give you blood pressure medicine to accommodate for the high blood pressure caused by the caffeine, then people will have a good blood pressure during the day, but it may go down in the evening. So caffeine makes it a little more difficult because it causes this to occur. So we really do ask people if they have significant high blood pressure to really back off. And I have some people that'll come in and they're 20-cup-a-day coffee drinkers. And what happens if you go from 20 cups to 0 in a day? Yeah, you get a headache like a knife through your eyeballs. So they have to, it's a drug, and they're addicted to it. So they have to back off on it slowly. So I tell them to cut it in half every 2 weeks until they're down to 1 cup. But caffeine is a real problem. Any other questions about what you can do without any medicine for blood pressure? So when I see somebody in the office for the first time, what I go through is all the things we just went through, and then I tell them if the blood pressure is not really bad, to come back in 3 months and let's see what the difference is. So what percentage of people do you think change anything? Yeah, pretty small. It's really, I mean, this is really quite straightforward. There's no mystical magic. It makes sense, but nobody does it. The smokers don't stop smoking, the coffeeers don't stop coffeeing, the eaters don't stop eating, the salters don't stop salting. Everybody keeps doing the same thing, so they come back 3 months later with no change. So now what do I do? Now I'm relegated to medicine. Now medicine comes in several different categories, and we can accomplish different things with different medicines. So we have medicine that can actually slow how much blood the heart is pumped by the heart each time it beats. We have medicines that can slow how often the heart beats, so we can take a heart rate from 80 and bring it to 60. We have medicine that can dilate blood vessels. So if somebody has constricted blood vessels, we can dilate them. We have diuretics that can make you piss your brains out. If you don't replace the salt as fast as you're peeing it, we can get the extra volume down. Oh, let me just backtrack for 1 minute. I know that somebody has extra salt by swelling in their feet. Okay? So anybody that comes to me with swollen feet, I know right away that they're consuming salt and water faster than they can get rid of it. It doesn't tell me how much they consume or how much they get rid of, only that it's coming in faster than it's going out. Anybody question that? So I do 2 things to try to figure out how much salt, because they all tell me they consume no salt. The first one is I do the Campbell's Chunky Soup test. Now Campbell's Chunky Soup is the saltiest item on the planet. And we know that your mouth changes its sensitivity to salt depending on how much salt you consume. So if I'm consuming a lot of salt, my mouth becomes very insensitive to the taste of salt, and it takes a lot of salt for me to taste it. If I'm routinely consuming a very small amount of salt, then my mouth becomes very sensitive to the taste of salt, and a little bit of salt will taste like a lot of salt. So I give them the Campbell's Chunky Soup, and I say, just taste it and tell me what you think. Well, if they like it, and they eat the whole thing and want another one, then they consume a lot of salt routinely, because somebody who consumes a little bit of salt will take 1 mouthful, and if they don't spit it out, they're choking it down because it's so salty and they won't take another taste. That's the Campbell's Chunky Soup test. The other one is I actually measure how much salt somebody consumes by looking at what they put out in their urine. And I know that if somebody's not gaining or losing weight, then all the salt they consume in 24 hours is going to come out in the next 24 hours. So I give them a container, and I say, just pee in it for 24 hours. So I had a gal in the office 2 months ago. She comes in, swears on a stack of Bibles she's consuming no salt, and her feet are like tree trunks. So I said, all right, here's a 3-quart container. I want you to fill it for me, 24 hours. She says, I don't really make much urine, but let me take a second container. And unbeknownst to me, on the way out, she asked my secretary for yet a 3rd container. Mind you, she's telling me she doesn't pee very much. To make a long story short, in 24 hours she put out 8,000 cc's of urine, which is 2 gallons of urine. And the average American diet is 7,000 to 9,000 milligrams of salt. A low salt diet is 2,000 milligrams, and she put out 40,000 milligrams. That's a full-time job to consume that much salt. I mean, we're talking several bags of potato chips. So people are not always honest with me. And when I told her this, she basically threw the chair against the wall, stormed out of the office telling me she would make sure my license was revoked because I'm a horrible human being. So people don't like to hear the truth. And she knew. All right, so we now have an idea of what we can do without medicine, so let's start digging into some of the medicines. If I have somebody whose blood pressure, the top number is a problem, but the bottom number is not, then we use medicines in a class called beta blockers. And beta blockers actually bring the top number down and leave the bottom number alone. We have calcium channel blockers. Half of the calcium channel blockers attack only the top number, and the other half attack only the bottom number. We have vasodilators, and these attack primarily the bottom number. Now, if somebody is stressed, is it going to affect the top or the bottom number? Very good. Not many people get that. So if somebody comes into my office and their blood pressure, let's say the ideal is 120 over 80. So they come in and they're 130 over 100. And they tell me this is stress. I know it's not stress. Because stress is going to cause the top number to be 160 or 170, but the bottom number is not going to go up too much. So if their primary problem is the bottom, then that's usually constricted blood vessels and not stress. Caffeine can do that. Smoking can do that. Because anything that constricts the blood vessels is going to primarily affect the bottom number. So now I have the ability with medicine to really tailor the medicine to the needs of an individual. Now, for a long time, we had something called bioimpedance, which was a device that with two little sticky things on the neck and two little sticky things on the rib cage would tell me how much blood the heart is pumping, how much fluid there was in the chest, and how constricted my blood vessels are. And this technology is no longer available, but when it was, we were actually able to tailor our treatments to the individual needs of the patient. For example, I would have somebody who's on blood pressure medicine and their blood pressure is 120 over 80, and I'm congratulating myself on a job well done. Except they say, I used to be able to play 5 sets of tennis. Now in a half a set, I'm so exhausted I can barely move. And my wife is ready to divorce me because we can't have sex because I can't get an erection. I caused it with the blood pressure medicine. And when I would put them on the bioimpedance study, what I might find is that I've constricted blood vessels and I've slowed the heart so that they weren't pumping very much blood. But because it was a balance screw-up, their blood pressure was actually perfect. So when we changed it around and gave them vasodilators and backed off on the stuff that slowed the heart, their energy level came back, their impedance went away. So there are lots of people that are on blood pressure medicines and have side effects that are truly intolerable. And it doesn't have to be. We have 170 blood pressure medicines. When you have 170, it tells you up front, there is no perfect one. We also have lots of combinations. And the combinations cause a problem because the balance between the different medicines is fixed. I can't change it. If I have 2 different medicines rolled into one tablet, the balance between the 2 is etched in concrete. If I give them the 2 individual medicines, now when we go to diuretics, and I'm backtracking again a little bit, when we go to diuretics, we have two different classes of diuretics for blood pressure. We have diuretics that work on people that have no swelling at all in their feet. And those particular diuretics bring down the volume of blood a little bit, but they actually dilate the blood vessels a lot. The other group of diuretics are for people with swollen feet that we need to get rid of a lot of salt. In the people that don't have any swollen feet and are on a diuretic, they don't urinate a lot. You wouldn't even notice that you're on a diuretic because the effect is very slow over 24 hours. The one where you have swollen feet, it's really aggressive and abrupt. And they will urinate a lot for a couple of hours and then it goes away. Those are the people that say, I'm stuck in my house for the first 3 or 4 hours out of every day. When those people tell me they're stuck in their house and the swelling isn't going away, what it's telling me is that they're replacing it as fast as they're peeing it out. And I can't help but emphasize this again and again because this is critical. If you can get the salt under control, the majority of blood pressure becomes very easy to control. If you don't get the salt under control, I have some people on 4 or 5 different medicines and their blood pressure is still minimally controlled. Now, yeah.
Mostly everything has salt in it. You know, everything you eat. When you look at the labels, you go to the grocery store and you look, the sodium, the high content of sodium, isn't that salt?
Yes, it is. And I can't argue. I can't argue with you except to say, then I'll use soup as an example. There are soups with as little as 100 milligrams of salt in a can, and other soups with 1,500 milligrams in a can. There are string beans, canned string beans, with 850 milligrams in a can, and it's sitting right next to one with 50.
And no salt.
Right. So, yes, everything has salt, but in every kind of item that's out there, they're now starting to make items with less and less salt in it. 5 years ago, we had a real problem in the supermarkets because they brought in a lot of low salt items, but we hadn't yet evolved to the point where salt has the same negative feeling that it has today. So they would bring in all this low salt stuff and they would throw it out because it was expiring on the shelves. So then they stopped marketing it because if no one's going to buy it, why should they try to sell it? But now there's a whole big resurgence of people that are becoming a lot wiser with salt. So I know the string beans are there because I get the no salt string beans. There are potato chips now. Wise makes potato chips with no salt. Lay's makes them with low salt. And they're not bad. So I think if you really sit down and try, you can really get away from a lot of the salt. What?
It's very difficult.
Oh, it is. It's quite challenging. And what I tell people to do is take the top 20 items that you routinely buy on a regular basis, divide it into groups of 3, and let's take bread, plain old white bread. If you go to the store, you're going to find there's 8 different kinds of white bread. Get 1 loaf of each, sit on the floor, and look at the salt content. You'll immediately realize that no 2 loaves have the same amount of salt. Find the one with the smallest amount of salt, and that's the one you start buying. Fortunately, supermarkets stay with the same items for years. So it's not every day that you're going to go in and find there's a new brand of bread that's cropped up and another one's disappeared. Fortunately, that doesn't happen. So then you need to write down the brand that you want. And you start to go through all the items that you routinely buy, and you figure out which ones have the smallest amount of salt. It's a real effort, but the benefits are so extraordinary that it really is worth it. And
You're talking about the soup, the Campbell soup.
Mm-hmm.
The Progresso is high, very high in content of the salt, sodium content in one can. At least 1,000.
Well, the soups are really ridiculous to begin with, but there's 100 different there's 100 different kinds of soup out there. You just really have to sit down and figure out which is the best one. Of course, if you can make it yourself, you have much more control. Right, but I have some patients that make it themselves, but they put bouillon cubes in it, and they don't realize that some of the items that they're putting in, because they're not using the salt shaker, the end result is low salt. People can their own stuff, but they'll can it with salt, but because they canned it, it's better salt. And sea salt is better than regular salt? Well, that's a bunch of hooey. Salt is salt. So whether it's Himalayan salt, sea salt, land salt, the only value of sea salt actually is iodine. The sea salt has iodine in it. But as far as its salt content, it's exactly the same amount. Now, 1 teaspoon of salt is 2,500 milligrams of salt. 1 teaspoon, just to give you an idea. And a low-salt diet is 2,000 milligrams per day. And I have people that come in with enormous feet, they're on diuretics, and they swear to me that they're on 500 milligrams of salt a day. In metabolic units, in research labs, I can't get to 500 milligrams. But they've done it. Any other issues on salt? We'll lay this one to rest. Yeah.
I have a soup that I made, lentil soup, no bouillon. The only salt that gets in it is from the canned tomatoes that are in it. And if you would use, your own tomatoes, no salt at all, and it tastes fine.
Well, I'm going to tell you the fine taste is something that takes time. Because when you go on a low salt diet, your mouth will start to become more sensitive to salt. But the food for somebody who's used to a lot of salt is going to taste bland for a while. But over the course of a few months, their mouth will become more sensitive, and the natural salt in food will make it taste right again. So you can desalt. Any other questions on salt? Okay, so let's take our blood pressure medicines again. We have the ability to vary what medicines we give that's based not only on whether it affects the heart's ability to pump or the constriction of blood vessels, but actually its ability to get into tissue. So we have medicines now like Indoral, for example. I don't know if any of you, it's an old beta blocker. But it used to get right through the blood-brain barrier, cause nightmares, a lot of impedance. Sorry if I keep looking at you when you talk about that. All right, that's good. We had a lot of impedance and a lot of problems with it, and then we came out with later generations of beta blockers, like low pressure, for example, that does not get through the blood-brain barrier at all. So we had people that had impedance problems, nightmares on Indoral, that when we switched them to a similar effective beta blocker, but one that was less lipid soluble, that all those side effects went away. So I'm going to present to you that you can be treated with blood pressure medicines, get your blood pressure under control, and not have intolerable side effects. And if your doctor says you have to stay with what you got, no matter how miserable it makes you, that's just wrong. And I get people that come to my office because that's their issue. That yes, my blood pressure is good, but life isn't worth living like this. And we're able to get them on different medicines and change that. All right, questions for me? Yeah.
What about low pressure when you're...
Well, if it's pushed lower than 60 by medicine, then your doctor needs to back off on the medicine a little bit. The studies are very powerful that it's just wrong now to drive it down. Now, if it's naturally less than 60, that's a totally different story. There are petite women whose blood pressure, the top number is 70, the bottom number is 40, and that's where their body is. And they do just fine. We also know that the blood pressure is 10 to 15% lower when you're sleeping than during the day. So if I have somebody who's 110/70 during the day on medicine, and they wake up and they're 90/50, I don't have a problem with that. Okay, as long as their bottom number is over 60 during the day, nature does drop it down, and it's organ protective. And I have many, many patients that I see because their kidneys have been beat up by high blood pressure. And if we can get their blood pressures under superb control, their kidneys stabilize and sometimes actually improve over time. So I am not afraid of less than 60 when they're sleeping or first thing in the morning. More questions? Yeah. Okay, now are we talking medicine-induced, or that's just where the natural blood pressure is? Okay, well let's start with, if it's medicine-induced, then that's a clear-cut indication that you need to back off on some of the medicines. And we see that more in people that are older and their blood vessels are stiffer, and those are the pseudo hypertensive patients, where if I could put a little tube inside their blood vessel and measure their true blood pressure, it can be 20 to 30 points lower than what I get with my blood pressure cuff. And those people, we need to back off on the blood pressure medicines. There are some... Do you have a question?
I'm sorry, I don't know what was the symptom that she was asking about.
Just lightheaded and dizzy when you stand.
Thank you.
You're welcome. So if it's induced by medicine, then we need to back off on some of those medicines. If it's just they're not on blood pressure medicines and the blood pressure's low and they get dizzy and lightheaded, then there are medicines that we can use that artificially constrict the blood vessels and prevent the pooling of blood when somebody stands upright. And let me backtrack another thing about blood pressure medicine. There are some people that when they go from lying to standing, they get a couple of seconds of lightheadedness and then it goes away. In those people, all right, let me back, this is really interesting stuff. When you're standing up, how does the blood get from your feet back up into your chest? Do you think it's from the energy from your heart? Okay.
Volume pushing.
What?
Volume pushes it.
Okay.
Explain it.
How do you think? How does it get back up there?
There's
Valves.
valves
Valves.
in your vessels that
Yeah.
bring it back up the right direction.
Okay. Well, valves would get direction. No, the heart does not pump it back up. Right. When you walk, the blood vessels in your calves squeeze the blood vessels in your feet. And there are valves that only allow blood to go upward. So when you're taking a step and you contract that calf muscle, it squeezes the blood vessels inside the calf, pushing blood up. Then when you relax the calf, they refill. So the movement from your feet when you're upright is from walking. That's why when somebody is sitting in a car for an extended period of time, or they're on a very long airplane ride, they're at a risk for a blood clot. A blood clot in the leg because there's not that kind of movement. When you're laying down, how does the blood get from your feet to your head? Well, when you're laying down, it's from the energy of your heart. And for that to occur, the blood vessels have to get really big, so there's very little resistance to flow when you're horizontal. Okay? Now, when you're horizontal and the blood vessels have all dilated so that there's very little resistance to flow, and then you stand up, the blood vessels in your feet have to snap closed really quickly. Some of the blood pressure medicine makes that response quite sluggish. And as a consequence, there can be a temporary pooling of blood in your feet. And then the blood vessels constrict, but they'll constrict over 3 to 5 seconds instead of instantly. And when you have that delayed constriction, you can get a little lightheaded until that occurs. In those people, you can sometimes change their blood pressure medicines, but sometimes you have to tell them, when you stand up, just hold on to something for a couple of seconds. When that passes, they can then go and do their thing. Okay, so now let's go to somebody whose blood pressure is just naturally very low and they're getting lightheaded. Those people, sometimes there are certain circumstances where the body cannot hold on to salt. And in those people, we give them medicines that cause their body to hold on to salt. Sometimes we give them salt tablets. There are people that are actually salt deficient. They're pretty rare, but those people do exist, and we have to give them actually just things to hold on to salt and extra salt. There are some people whose blood vessels are naturally very sluggish, and we do have medicines that can make the blood vessels in the feet constrict faster and minimize the likelihood of being dizzy. And Anne has a very valid point that when you get that lightheadedness, if you're not aware that it can happen and you just get up and start moving, you could fall and hurt yourself. And every once in a while we do see that. A lot of people ask me, if my blood pressure is good, can I back off on my blood pressure medicine? Who thinks you can do that? Well, that's true, but I have to tell you that we were guilty of having the same thought about 10 years ago. So if somebody's blood pressure came high, and I put them on medicines, and in 3 months I got their blood pressure 120/80. And a year later on the same medicine it's 120/80. Then we started to think, well, maybe like a car, when you get on the parkway, you need a lot of gas to get up to 60, but not a lot to maintain it. Maybe once you got the blood pressure really good, you didn't need as much medicine to keep it good. So we started to back off on blood pressure medicine. And I'll just use percentages. Let's say somebody, we back off 10%. And they come back a month later and their blood pressure is still 120/80. This is great. Backed off another 10%. Still 120/80. Backed off a third time, and now they're 150/90. So you say, aha, if I go up 10%, then I'll have them at the last dose that was effective. But when I went up 10%, they stayed at 150/90. And when I kept increasing it to where they were to start with, they're still 150/90. And it took 150% of the medicine that I originally had them on to get them back under control. And I thought I was, ridiculous with this. And then I went to a national meeting, and the whole topic of the darn meeting was how we shouldn't be backing off on these medicines, because we didn't know how far to back off. The end point of backing off was when you lost control. Because otherwise you kept saying, there's still 120/80, I can go even lower. And we had no way of knowing how low you would go until all of a sudden they were out of control, and then to get that control back was much more medicine than before. So we've all abandoned that, except we do have occasionally patients that are obese, and they lose a lot of weight. And if they do lose a lot of weight, then the drive for their blood pressure is much less, and that group it's legitimate to back off on their medicines. Other than that unique situation, which doesn't happen all that often, but other than that, we don't back off. If we have good blood pressure control, I leave them on it for 10 years if it stay good. Now, the natural history of high blood pressure is that it does get worse over time. So what we find is that blood pressure may stay stable for a year or 2 or 3, but eventually there's a creep that occurs, and I have to make adjustments in the medicine. The impression of the patient is, my body has gotten used to the medicine and it's not working anymore. But in reality, the natural history of the blood pressure is that it is increasing. So the medicine is just as effective as before, I just need more of it. Because the blood pressure drive is higher now than it was a year or two ago. So we don't accept that the blood pressure creeps with time and that's perfectly normal. We have to keep it down. If you go back 10 years ago, the number one cause of congestive heart failure was a burnt out hypertensive heart. We don't see that anymore. All right. Questions for me? Yeah.
Is there any relationship between heart rate and blood pressure? So people with higher heart rate have lower blood pressure.
Now, I say no, but if you get really fast, like 150, 160, then there isn't enough time for the heart to refill, and then cardiac output goes down and the blood pressure goes down. But if you're going between 80 and 100, there would be no difference. And people who exercise, they'll get their heart rate up to 150 and they're chugging out 10 liters of cardiac output. Yes?
Is there any of the high blood pressure medicines that can cause your potassium to get high?
Yes. You would like me to enumerate them?
I just was wondering because I've had several high potassiums and
Is your kidney function normal?
yeah, the EGRs are always good. So.
Okay. I will talk to you later because I know what that is. Lisinopril can cause the potassium to go up, but it does it consistently. It doesn't do this unless your diet change. If it's always high, that's different than sometimes high, sometimes normal. Now, lisinopril has a lot of real value. If you have diabetes, it can slow down the rate of diabetic kidney damage, heart damage, eye damage. Incredibly valuable. If you cannot get your potassium under control with diet, now remember, the only source of potassium is from your food. So in almost all cases when someone has a high potassium, if we do a diet count, we just have them write everything down that they're eating for a week, we almost always find where the potassium is coming from. If you can cut it out and keep your potassium reasonable, we can stay on the lisinopril. If your potassium is too high, we have to stop it. And then you lose the benefits from the lisinopril. Aldactone, another one, it's a diuretic, a potassium-sparing diuretic that we're now beginning to realize has enormous ability to be cardioprotective, kidney protective, and eye protective. But they all retain potassium. Now there's a new medicine that was just FDA approved a month ago that is now going to be used in people who are on lisinopril whose potassium is not controllable to allow them to stay on lisinopril. It just got FDA approved. I can't even tell you the name. It's like this long. So there's stuff out there. Any other questions? All right. Thank you all.